So my presidential address is taking us along our journey from 2003 to 2020. It really is a cause for celebration. In 2003, I was the chair of the conference committee, and Barbara Sewell was our president, and we had our theme, the expedition to the future. And I want to take just a moment to thank all of my mentors who were so supportive in me in my own journey, but they also were very critical to charting the course for us, as well as were participants in our strategic plan and providing us their wisdom and guidance. So Dr. John McGowan was our keynote address back in 2003, and he said to us that infection control really wasn't trendy until 2003, when we were needed to help with the smallpox vaccination of our healthcare workers, the bioterrorism issues, and SARS was so rampant at the time of our conference that many of our speakers had to cancel because they were so busy in Toronto. And it was at that time that our president, Barbara Sewell, announced that they are really looking for colleagues to help the infection preventionists in their country. And we had a number of volunteers that were inspired at that day. The other thing that happened right before the conference was another speaker who had to cancel because he was working on an outbreak and identifying monkeypox in a hospital system in Wisconsin. And we had what people thought was a cutting-edge conference that was really a fill-in for the speaker who couldn't come, but we had a wonderful presentation on smallpox. And at that time, we had many challenges, and Linda Goss actually was quoted by Dr. McGowan and saying that we were really in an aggressive time for infection control practitioners, but we were laying the groundwork for a much larger plan with building relationships that really would help us in our comprehensive efforts moving forward. So I reflected back on that time and felt a lot like Semmelweis, that we were trying to carry the mission of infection prevention and targeting zero, and felt that we were being challenged by so many of our colleagues that any change was difficult. Any change is going to have drawbacks and discomforts. But back in 1999, we took on the challenge of the Institute of Medicine report to Err is Human, where for the first time we were hearing that hospital-acquired infections was a medical error. And Dr. Julie Gerberding, the director of CDC at the time, was the first to publish in 2002 targeting a zero rate. She actually said that we should not be striving for the benchmark, but striving to be below the benchmark, because then we would have much more robust reductions. She also challenged us and said to start using some of the safety tools, like the root cause analysis. And it was a new concept for us to look at healthcare-associated infections as defects, really analyzing what happened and why and what could we do to improve. My proposal for 2020 is a concept of now taking that time to do a root cause analysis at all of the patients that were so complex and in critical care for a long period of time and did not acquire an infection, to celebrate that human person, that we are preventing infections, not so much that we're harming, because our vision is that we are going to reduce harm. Because once we share these learnings with our team, it will give them that, will be influencing them and inspiring to keep moving forward. So back in 2003, one of our abstracts for dialysis was using a benchmark. Today, there's an abstract on preventing CLABSI in the dialysis patient with a collaborative approach. Newsweek published that perfect is possible in 2006. Dr. Denise Cardo, our Director of Healthcare Quality and Promotion, along with Denise Murphy and colleagues, published the white paper on moving towards an elimination of healthcare-acquired infections. Our consumers were our strong advocates as well, and they published that perfect is possible in 2011, and that average isn't good anymore. A dear friend as well, Dr. Arjun Srinivasan, published in 2002 in May that the power of public policy and our state collaboratives with the healthcare-associated infections coalitions have changed the paradigm for infection, because the new normal now is that each healthcare-associated infection is potentially preventable. Now, some of our critics have blogged that why should we strive to eliminate CLABSI, because we know how to do that. Well, my esteemed predecessor, Russ Olmsted, says, well, let's take a look at the evidence. So in March of this year, positive deviance was published as a strategy to reduce bloodstream infections. Back in 2003, we were learning how to apply the new CDC guidelines and having maximum sterile barriers or using a chlorhexidine alcohol solution to prep the site. It did take us a while to get some of our clinicians to move along with that, but those efforts back in 2003 were reducing infections down to 29%. Our vital signs report from the CDC is showing that with all of our public reporting and our collaboratives, we hit a 58% decline in our bloodstream infections. And now in Hospital Compare, not only can the public compare, but we can. We can look at our colleagues to see what have they done to sustain the lowest CLABSI rates in our country. So when we look at some of those folks that have questioned, is zero even possible, they can compare themselves now to other like universities. The Comprehensive Unit-Based Safety Program, again, was a collaborative teamwork approach, and those reductions for bloodstream infections achieved a 35% decline. But in the 2011 ARC report, we're learning that there are some barriers to sustaining those improvements. Whenever we take our eye off of the infection prevention measures for a particular strategy, the rates won't be sustained. And we do need to continue to look at every infection to identify a process that must be improved to prevent infection in the future. So back in 2010, we had our I Believe in Zero campaign, and Dr. Peter Provenost, among our many collaborative partners with IV management, formed this strategy. And once again, we were getting some press about zero as well. And to quote the blog, so once again, I'll be speaking on getting to zero, a myth so big it rivals the tooth fairy. Believing in getting to zero requires ingesting an awful lot of Kool-Aid. That was posted on April 22nd of this year. But our colleagues are still believing in zero. Our critical care associations, along with the Health and Human Services, is acknowledging the work of working towards elimination and hopefully someday preventing all healthcare-associated infections. And I just want to take a moment that my hospital was one of the very first recipients of the inaugural award. And for me, it was teamwork, collaboration, the belief that zero was possible. I never believed it was possible, but my team did. And we have made great strides in so many of our different clinical action teams with that belief. Dr. Sanjay Saint published in ICHI in 2010, How to Jumpstart Infection Prevention, with a new strategy called Implementation Science. It looks a lot like the PDSA cycle, but there's something totally different. It's working with our partners and allowing them to come up with the solutions. We are there as their experts to, first off, we do have to have engagement from our senior leadership team and our executive offices in the C-suite, but we want to share the evidence. That's our expertise. Then we want to execute the plan, but take a look at all of those learnings. Remember, any hospital-acquired infection is a mistake. So what could we learn from that experience? Change the practice, have those frontline workers be your advocates, because it's really all of our jobs to prevent infection and then, of course, perform in doing your measurement. So there's a new strategy that the healthcare educators in all of the universities are looking at. And it's all based on the 2001 Institute of Medicine report that says we really have to change the way that we are both training our healthcare providers as well as continuing their competence. So a new term published in 2012 was interprofessionality. It's competencies that are all around teamwork and all of these other domains that you see here. Again, Dr. Provenos was quoted that we all have a moral obligation to work together to improve care for patients. And some of their core competencies is, again, teaching them in their med schools and nursing schools and dentistry schools about the process improvement strategies and the important work of teamwork and team-based care. So their core competency model, using the Institute of Medicine report, it looks quite a lot like the one that you'll see with our model, the APIC competency model. Back in 1999, I don't know if everyone ever caught that, back then they said there really needs to be a re-examination of how we assure our providers are providing safe patient care. And in 2009, the Agency for Healthcare Quality posted the Patient Safety Networks article, "To err is human, to delay is deadly." Because 10 years after the Institute of Medicine report, we still didn't do anything about competencies. And continuing education alone was not going to assure competent caregivers. So in the ARC report, they say an ongoing competency examination is required to maintain certification because that has not yet been adopted. The Agency for Retired Persons also has done research, and they are pleading that a new regulatory model must be beyond mandatory continuing education to assure competency. In fact, next week, the Citizen Advocacy Center on Continuing Professional Development is meeting again about how the healthcare providers can demonstrate their current competence. Part of their strategy is to develop a national interprofessional continuing education institute to advance the science of continuing education. I want to switch a little bit more now to what has happened with our state collaboratives. So they did a report in 2012 among the input of many of our stakeholders that are here in this audience. And they said the most important indicators for healthcare-associated infection reduction was increasing the number of our trained, certified infection preventionists and greater participation in improvement plans. I don't know if you get these in your email, but the talent specialist firms are now publishing what these high-performing organizations, Magnet hospitals, they're adding to their staff, but they're also requiring certification. Now, we all hear about the barriers to taking the exam. First of all, I know we all have test anxiety, but the cost of the exam, lack of institutional support, and lack of rewards for becoming certified are all things that we've heard. But actually, that's exactly what the nursing boards have learned. So we're not alone in that feeling. So they published in 2011 best practices in creating a culture of certification. And we are really striving to do that this conference and going on. So at this moment, I would love to have all the certified infection preventionists stand and be recognized. Fabulous. Look around. Thank you for investing in yourself to demonstrate your credibility. And we do invite all of those that are studying for their exam to go to the CIC lounge. The booth that CIBIC has to learn more about becoming certified. So our colleagues in other professional organizations are saying certification is your personal best. It's a way to demonstrate excellence. Certification validates your specialty knowledge. We have such a special talent and knowledge. And to keep current with that knowledge, we need to keep becoming certified to demonstrate our mark of excellence. Now, many of you may not know that one of the magnet criteria for status to be esteemed as a magnet hospital is to have a higher number of certified caregivers. Well, the certification in infection control is one of those certifications that is recognized and qualifies in your organization as a measure of excellence. Leapfrog is another quality organization, and they recognize that magnet is a factor that exemplifies safe and high quality care in an important way for these hospitals to be acknowledged. And it provides the consumer with a reliable benchmark to measure the quality of care. The research has shown that magnet hospitals, the characteristics that they have is that 48 to 50% of their leaders or their decision makers in their organization are certified, and 29 to 34% of their direct caregivers are certified. Now, switching from a hospital to a long-term care setting, the Agency for Healthcare Quality has a toolkit for consumers to choose a great assisted living or long-term care setting, and certification in APIC was one of the very first criteria that they've listed here that their director of nurses should attain, as well as many of their staff having an infection control accreditation. Now, there's so many different handbooks that I looked at from all of these other professional organizations, those that were similar types of professions that we have, and they all have the same, why should I certify? So they all have the same message. But the Certification Board of Professionals in Patient Safety, it's a new certification last year, they have a 3-year cycle of re-examination. And they also say that a passing score reflects the point of a minimum competency for entry level as a certified practitioner. Joint Commission just announced their accreditation. They call it the JCAT. And so there's a growing demand in other organizations that are developing certification programs. Now, thanks to our PhD colleagues here, Monica Pogorelski, Patricia Stone, and Elaine Larson, they published the first, actually it's probably the third research article that certification does matter. And this hallmark article in our journal shows that growing evidence that becoming certified does impact quality care and prevent infections. Another great article and contribution that our editor, Elaine Larson, has for us is devoting this whole issue in May on our strategic plan, our value of certification, and also our competency, our new competency model. Got a lot of press, and we're very happy with all of the increased public respect and interest in our profession. So I look back to one of our esteemed presidents, John F. Kennedy, and he said, "The only valid test of leadership is the ability to lead and to lead vigorously." He said, "Beyond the new frontier are uncharted areas of science, space, and unsolved problems." If you want to change the culture, you have to start by changing an organization, says Mary Douglas. So we're moving our profession forward. We're changing our culture with our new competency model. And the chair of our competency paper and our model is Denise Murphy, and you'll hear more about that, as Katrina said, in the session coming forward tomorrow. We're excited that we have a new professional development council. The liaison for this council is a certified infection preventionist, now on staff, Marilyn Hatchett, at our headquarters. And Janet Haas is the chair of this new professional development council, where we are going to be developing tools to help you be successful in your new career path. Back in 1961, John F. Kennedy said, "I believe this nation should commit to achieving the goal of landing a man on the moon." Now you know how that was back in 1961. Somewhat like in 1999 or in 2002, that 0 is our goal. But just 8 years later, we had a man on the moon. He also said it would be easier to shrink back to look to the safe mediocrity of the past. And as we look at the end of the shuttle program, there are still positive people thinking that still could be the boon for the next wave of outer space. So please join me as we collaborate with our partners in the Health and Human Services 5-year action plan that by 2014 we have met our goals. So you can see we have some challenges. We have challenges with sustaining our gains, and we have C. difficile as one of our largest challenges moving forward in being able to meet that goal. So I think I want to start with a quote that Katrina Christ, our CEO, had. She said, "I think APIC and all the infection preventionists should continue to stand proud to bringing forward a culture of targeting 0 and demonstrating it has made an impact leading to the next evolution, reframing the conversation." So I look to another person that has 2020. Barbara Walters was the first U.S. woman TV news co-anchor, and despite the belief at the time that women had no place in the news industry, and was disdained by her co-anchor, she kept her mission going forward, and today is recognized for having the most famous interviews, the most toughest interviews, and is the only person that has interviewed every president since 1961. So I challenge you to join our journey, take pride in what you've done so far, and help us reach our mission to create a safer world through infection prevention. Thank you.